The goal of this panel is to address some of those issues that you face in an everyday sinus clinic or general clinic, and it's like, I wonder what I should do. These aren't head scratchers. They're kind of simple things. So the objective, discuss these decision-making options of what to do. This isn't a right or wrong answer. These are all things where you could do one of many, many things. It's not an oral boards examination for my panelists, so don't think of it as that. And in fact, just to show you, I'm going to tell you the diagnosis for all of these patients. So I just want to focus on the decision-making, your thought process of what you're doing with this patient in your clinic and what the next step is. First case in point, this patient has RARS, or recurrent acute rhinosinusitis. That's the diagnosis. I'm telling you ahead of time, so no surprises. 57-year-old female. This is her 5th sinus infection of the year. She does respond every time to antibiotics. She's symptom-free between episodes, so you're fairly convinced it's not chronic rhinosinusitis. And her nasal endoscopy is normal. First of all, would you have done a nasal endoscopy on this patient?
Depends on the time of the year. If it's January 1st, no, because they haven't met their deductible yet and I'll get an angry phone call. If it's December, then yes.
I scope everybody.
And what are you looking for on endoscopy in a patient with recurrent acute rhinosinusitis, or what you suspect that to be?
Well, I want to get the lay of the land, so look at their anatomy. Let's say they have symptoms always on the left and they have a severely deviated septum. I mean, I've seen septums cause recurrent acute sinusitis if it's causing obstruction of the maxillary sinus. You look for inflammation, evidence of rhinitis. You always want to ask them, is it a good day or a bad day? Are you sick today or are you not sick?
Why is that important?
Well, let's say they feel terrible and they think they're having a sinus infection. You're going to look for signs of an infection. And if you don't see any and they're sick that day, then that might be a good day to order a CAT scan.
Interesting. So Dr. Onstead, you were talking yesterday about getting this CAT scan when people are feeling better. What do you think about Dr. Ray's comment?
About getting a CAT scan now?
Yes.
Well, if they're sick.
Yeah, I think I'd get his CAT scan now, especially in recurrent acute. I think that would be an example of a time where I wouldn't wait until they're their best.
All right. So what if this patient says, I feel pretty good today? What would you do with them?
Me? Mm-hmm. They feel good?
Yeah.
What do they want?
They want to quit getting 5 sinus infections every year.
So have they had an allergy workup?
Not yet.
So that's something I would start with.
Okay. Excellent. Anybody going to get a CT? So let's say this patient is symptomatic today. This is Dr. Ray's patient. You get a CT scan. Dr. Picorni, what do you see?
I see a microphone. So I see a relatively normal CT scan with a small amount of mucoperiosteal thickening along the floor of the maxillary sinus. At least the left infundibula is open. We can't visualize the right infundibula. I'd like to know if it's open.
All right, it is open. Okay. And this is a different patient, and this is zooming in. I didn't get the OMCs, but you see some mucoperiosteal thickening on both sides. It's minimal. What do you do?
Well, for this syndrome of recurrent acute sinusitis, the first thing I want to know is how long do these illnesses last?
So generally, they'll say a few weeks, until they take antibiotics. Sometimes they go away on their own, but usually they have to take a round of antibiotics.
So this is pretty unimpressive, even for a viral sinusitis. And duration, less than 10 days or even 2 weeks, it's likely to be viral, in which case I say this is your normal cold and not much we can do, but an allergy evaluation is great. You're asking the guy that would say, with any time I see a patent infundibula and mucosal thickening on the floor of the maxillary sinus, I send him to my friend Dr. Tatarin, who's an endodontist. Because I always think about endodontic disease when they have maxillary floor disease. And sometimes they have recurrent symptoms, because sometimes they'll get an antibiotic or they'll have something. They don't always have chronic, everyday symptoms. So
of the 4 panelists, who thinks this patient has RARS? Raise your hand if you do. Nobody?
Well, I think the jury's still out at this point.
Is that normal? Is this a normal CT scan?
Well, it'd be a Lund-Mackay too. right? So,
But they feel it right here.
So
I
this
touch my
is this is the hard part, and this is what we all do every single day when we're seeing patients. You know, from the minute you walk in, you are assessing that patient and you are kind of sizing them up and you're trying to get an idea, okay, on the crazy scale, where are they? On the symptom scale, where are they? Do the symptoms fit with this? Are they like my mom who takes a Z-Pack every time she feels a cold and within 3 hours she's cured? You know, things that defy physiology, and so you're gauging all of that. And so I don't know exactly what this patient has right now. However, with recurrent acute rhinosinusitis, there's a pretty broad range of findings on those CT scans. With the scope, earlier I was kind of joking about the deductible to an extent, but I look for data, you know, so I look to see, are the middle turbinates wide and consistent with concha bullosa? Is there a septal deviation? Is there something else that could explain that? Is there pus? Is there a secondary accessory ostia? So I'm looking for all those things, and then you know, I will talk to them about this, and you know, is this their typical infection? Is this their typical infection? Have they waited the normal period of time? You know, so that's the hard part. And 99 out of 100 times, this patient will leave my office with the instructions: next time you feel your infection, you call me. And I'll say, when you call me, my first question for you is going to be, is this your typical infection? And is this rip-roaring? And I always qualify that as, not that I want you to be sick, but I want you to be rip-roaring sick when we get this CT scan, because that's going to give us the most data. And so that's how I leave it with them. So at this point, I don't know if this patient has
How many
RAS or
days
not.
do you want to wait from the onset of symptoms to when you get that CT scan?
I want to wait as many days as we possibly can. So probably a good, depending on the individual and depending on what we see and you know, depending on how many times they've called my office, it will vary anywhere from 5 to 10 days, but the longer the better. And my nurses are pretty good about really coaching the patients when they call to really try to tough it out for at least a week.
Okay, I want to ask the audience real quick. I'm going to ask you, is this an easy patient or a hard patient? Who thinks it's an easy answer to this question? Anybody think, anybody think it's a hard one? I think it is a hard one. Now, if I showed you a CT with a lot of frothy material in the sinus, that'd be pretty easy, right? But this isn't about the easy answers. These are about the hard answers. Dr. Picorni.
Yeah, one other comment. So a couple things we know is that if you go down on the streets of Seattle in the wintertime and take 100 people that are asymptomatic and do CT scans on them, you're going to find 20 people with scans like this. Second thing we know is that recurrent acute bacterial sinusitis, and we're not really differentiating, but recurrent acute bacterial sinusitis is actually a rare disease. It happens in about 1 in 3,000 people. Headache disorders are common diseases. They happen in about 1 in 5 people. And we know that in the primary care setting, headache disorders are more often misdiagnosed as a recurrent sinus problem. And so even though they have a little bit of disease here, that may not have anything to do with their symptoms or anything to do with what's going on. So all these ideas of seeing them when they're sick, doing an endoscopy, doing a culture, that's great. But with that information, that's what I'm thinking.
All right.
I had one little thing.
Sure thing.
So I think for all of us, when we get something like this in a history like that, we're trying to prove to ourselves that it's actually real, that this is actually happening. And so when we talk to them about, okay, these 5 episodes of acute sinusitis that you're getting, I would also ask for more detail to find out, is it a migraine? Is it a cluster headache? Is it allergy? Does it only happen during, when you're different exposures or to certain times a year? Or, and I would backtrack from yesterday and say, this is the time that I would get it when they're the worst, because I'm trying to prove to myself that it's actually happening, that it's actually a sinus problem and not some other problem like septal deviation and inferior turbinate hypertrophy and a concha bullosa or a contact point or something else.
Pete.
Great. Can I ask the panel, in this patient, I guess we're assuming sinusitis in this conversation, but when I look at that scan, I see potential for persistent mucociliary dysfunction. Knowing how much mucus those maxillary sinuses are creating. Let's say I follow this patient conservatively and maybe scan them 3 or 4 months later after they come in with a new symptom. But their complaint's not headache. Let's say it's thick mucus, okay? Does that change the panel's thoughts? Can I potentially open up that mucus, that area, and instead of combating it with a Z-pack, like Greg was saying, or the panelists, can I change the equation here? And if I think that I'm still having mucociliary dysfunction on that floor or medial wall of that maxillary sinus, can I get topical agents on that to break the cycle and maybe improve things? I mean, what's the thought?
What makes you think there's mucociliary dysfunction with that? I don't see any mucus in there.
So the thick, maybe I'm wrong, and please correct me. The thickened mucosa on the floor of the, for instance, right maxillary sinus, and even left, is that dysfunction? I always think of it like a factory with a conveyor belt. If the conveyor belt is inefficient, then yeah, maybe I'll get a patient with like, oh God, Maurice, I'm getting, constant mucus. What's your thought there?
I think if you look at 100 scans, you'll see 50 with thickening in the floor of the maxillary sinus. And there's some radiologists that call it sinusitis, and there's others that don't, which is why I always tell my patients I have to see the CT scan and not read the report. But thickening at the bottom of the maxillary sinuses, and even cysts, right? We know that retention cysts are asymptomatic, and they're found in roughly a third of patients. We see those all the time. I consider that a normal finding on a CAT scan.
I would consider this patient more dangerous patient than like the third revision polyp case.
So, you asked why we're thinking this is sinus, and mostly, I think, based on the data that we have, that's what the patient thinks they have. And the patient's been to urgent care 12 times and gotten antibiotics, and so that has been reinforced that it is an infection. But, Al brought up a dental problem. Al and Amy brought up a potential headache problem. So I think that the differential for us, everybody in the room, would be much broader than sinusitis. So I don't say that it can't be a mucociliary issue. I'm not saying that at all. I'm saying I don't know what this patient has just yet. And so, with that, is that normal, abnormal? I don't know. Is that clinically symptomatic or clinically significant? A lot of times is the term I will use with the patients. Probably not, is what I would guess. But at this point, I still don't know specifically. And I think what Amy had mentioned, by this patient more dangerous, I think there would be a much longer line of people willing to testify you if you hurt this patient with surgery than if you were to hurt somebody who's had recurrent polyps and has had 4 surgeries and those types of things. And that's my interpretation of her comment. I don't know if that's what you meant or not.
No, that's part of it. And so, but I would say more dangerous in just that I don't want to do the wrong thing to this patient. It's very clear when you have a patient who has horrible polyps and they've required multiple surgeries and we know that they have horrible disease. This patient,
They also give us the lowest reviews on Yelp.
Totally.
So I think it's unlikely that the consensus, unlikely surgery is going to change this patient's symptomatology, and that's something to think about. Now, we're going to move on to
Really quick, can I just...
this. Nope. So this is one thing I do want you to remember, though. For truly recurrent acute rhinosinusitis, we do have data that suggests that sinus surgery does help patients. It improves work productivity, decreases number of days lost, decreases number of days on antibiotics, and improves the SNOT 22 scores. Both this study, which is Peter's study, as well as Tim and his former fellows study. Pecker, you're not on that one, though. What happened?
No,
Anyway, Dr. Ray, what did you want to...
RAS.
What did you want to say?
We'll move on.
Okay.
We're on to a different subject.
All right, I have to get to, is this one it? No, not this one. I have to get to Dr. Mulligan's question about the osteoma. So we're going to do probably just 1 or 2 more cases here. This is one that continues to bug me. The minimal frontal sinus disease, a little bit of mucosal thickening in the frontal recess. What do you do? So here's a 50-year-old female, right-sided midfacial, periorbital pressure, nasal congestion, gets improvement with antibiotics and steroids. Does have some osteometal complex edema on endoscopy. The CT scan shows this. And I know, guys, it's a lot bigger if you turn around and look straight behind you. And let's just focus on, obviously, the right maxillary is easy, and there's concha bullosa on both sides. But what would you do, and let's say they failed appropriate aggressive medical therapy, what surgery are you going to offer this patient? Are you going to offer frontal sinus surgery or not? Dr.
No.
Ray.
He's
It
gonna
hurts
balloon.
right here, right side of my face, Doc. I can't touch my face, but it hurts right here.
The
right
right
here.
side or the left side?
Right side. That's the right. You're turned around. That's why it's backwards for you.
That's
a joke.
right,
Nobody
yeah, but
laughed.
there's mucosal thickening in the left frontal. That's
true.
why I'm
We're
asking
focusing
about
on the
frontal
right
sinus.
side too. That's true.
So
That's a horrible sell up there, isn't it?
I would open up the I would open up the ethmoid, and in the process probably open up the frontal. I would.
All right. Thank you for being definitive. You don't lose points. Dr. Pecker?
I would not. I would open up the right maxillary and do an anterior ethmoidectomy, and that alone will take care of it.
And you think that frontal recess is going to get better by draining that maxillary sinus and anterior ethmoid?
Yeah, it's a common final pathway. It's downstream obstruction. So there's a log jam by the maxillary. You relieve that log jam, and the frontal will drain much more effectively.
Amy, what do you think about that?
I think if this patient came in, I would open it. But I will say, if you decided not to open it, I would say that is perfectly fine.
The downside of not opening it is that you might have to go back and open it later, right?
And I think
Isn't that
is
our concern?
That is it's my concern, but I think that's, if you decide not to do it, I think it's perfect, it's conservative, and it's perfectly reasonable. Just because I would open it doesn't mean it should be opened.
Great point. Al, what do you think about that?
So you're talking to a guy that does hardly any balloons, but this might actually be a good balloon case. Relatively isolated disease. I'm assuming the maxillary sinus would be easy to flush out and get that out of there, and you could do this case in your office in a half hour and be done with it.
Interesting.
So
from the audience, I want to see who would and who would not open up the frontal sinus. So raise your hands if you would open up the frontal sinus. Raise your hand if you would not open up the frontal sinus. All right. So I don't know if this panel discussion helped your decision-making or not. As I said, this is all about these challenging decisions we make. No, you can't get to it through the external auditory canal, Doug.
Where is the frontal sinus?
So tough answer, but Amy, I really appreciate your answer on this. I think, it's your comfort zone as well, and the discussion you have with the patient. If the patient says, I want one surgery, I don't ever want surgery again, do everything you can, that might change it into opening up the frontal recess. But if they say, I just have maxillary disease or maxillary pressure, I don't have anything in the supraorbital region, then maybe that would push you into not opening up the frontal recess. There's no right answer, like I said at the first slide. This one, we can talk about this. This will be, I think, short and sweet. I went through a lot of different versions of what to call this disease. I had ninja sinus disease and skipping sinus disease, and I ended with mobile sinus disease. 58-year-old, boy, I'm picking on the women today. Sorry about that. 3 prior sinus surgeries. She's complaining of discolored nasal drainage and mild mid-frontal sinus pressure. Had a head CT scan, so not navigation. And the head CT scan showed this. It shows it's going pretty quick. A little bit of right frontal sinus disease, and it's right where she's having symptoms. And you're like, all right, you've had 3 surgeries from other folks. They sent you to me to do your frontal sinus. I'm going to do your frontal sinus because you're having symptoms there and you haven't got better with aggressive medical therapy. Let's get a navigation-compatible CT scan. So 3 months later, when you're ready to do her surgery, the day before surgery, she comes in early. You get the scan, and now all of a sudden she has left frontal disease. A little bit of right frontal disease. Her symptoms are the same, kind of centered over the right orbital area. And so this is it. You got April and July, and again, it's a lot better for you guys on the backside. You're taking her to surgery the next day. You've already consented her for a right-sided disease, and now you see this for navigation. What do you do?
Well, I would have planned her for a Lothrop in the first place, so.
Okay. That's an option. Anybody else? I probably wouldn't have. Well, I didn't show you the sagittal. She has a lot. She has a nice AP diameter. There's going to be room to
It's just like
probably
a really narrow recess, so I worry about it closing off. Or I might have consented her for a frontal and said, there's a possibility that you have
Okay.
a really narrow recess. It could close off, and if it does, then we'll have to do a low
Yeah,
throat.
that's
You
a
have
nice
that conversation
option. If you
frequently.
have not, you haven't been the one to do the surgery. So would anybody not operate on this left side? Or would you say, look, now this is showing disease on both sides. Let's open up both frontal recesses.
You're taking her 100% to the OR.
She's going to the OR, yeah.
Yeah, you got to look. I mean, you got to look at both sides. I mean, you can make the decision.
So you're
when
going to adjust the consent form and do the left side.
Well, you're going to look at both sides. You're going to show her the CT scan and say, look what crazy thing just happened to your CT scan. And then you're going to say, this is a weird thing. This wasn't what we were expecting, but you're only having symptoms on the right side. Is that right?
Yeah, kind of mid-frontal. I mean,
Mid-frontal.
Yeah.
Okay.
Mid to right.
And I would put Lothrop on the consent form, but I don't think I would say 100% we're going to do a Lothrop, but I would look, and often I do this where I say there could be a Lothrop. We could do a Lothrop, but it's not necessary.
Okay.
So
I want to steer us away from a Lothrop
so if you
discussion for this.
Yeah. So if you get in there, and you're looking at both sides, and there's something that you can open to give her a more open frontal, but if you look at it and you're like, oh, that's open, that's
Okay.
so it's and I think that's something that a lot of people don't realize is that when we're intraoperative, I'm changing my mind. I'm molding the surgery to the patient and then to the disease that I see and have seen and the history of that patient.
Okay.
So I don't get in the operating room and say I'm doing this in 100% and that's it.
Dr. Pecker, you look concerned.
Yeah, I don't know what to do with this patient. I think seeing that first CT scan, the symptoms, everything, seemed to align and make sense. And I think talking to them about a surgery and offering them that right frontal sinusotomy, I think made perfect sense. But, we all know that's a snapshot in time. And so if we get another snapshot and it's the completely opposite sinus, they're having the exact same symptoms, and the area that I thought I was going to operate on is clear, well, then there's no point in operating on that sinus. So I don't know. This would really make me reconsider any kind of surgical intervention at this point and really reevaluate how we have managed this patient medically.
My enthusiasm was not to completely confuse everybody in the audience, but I think we're heading there. This is, here you go, Lisa, this is it. 65-year-old female, new case, chief complaint, mild, annoying 3 out of 10 pain in the left midface region for about 8 months. And she comes in with this CT scan. And Lee, can you get my slide back? It just disappeared. Now I have 3.5 minutes. I actually get as long as I want because I'm the course director. But we're going to end on time.
Which slide are you on?
I'm just going to click the button fast. Uh-oh.
Oh, boy.
So this patient has osteoma. And the interesting thing is, and she's got this, let's see if it works. She's got this little tiny osteoma right there hanging off the skull base. And I think I get a snapshot. So there it is. And by the way, she says, I'm going to Disneyland in 2 months, because you talked to her about surgery. She needs sinus surgery anyway for, I forget what sinus it was. Oh, right there, the sphenoid. And you're like, well, you got this osteoma there as well. And she's like, oh, okay, should I take it out now? And you're like, yeah, the risk of a CSF leak is kind of high. We don't know the growth rate of this. She's like, well, I'm going to Disneyland in a month and a half. And if I get a CSF leak and can't go on the rides, that would be devastating for me and my family. So, what should you do with this?
Don't touch it.
That osteoma is not causing her pain. Don't mess with that.
Dr. Corney.
I agree. I wouldn't touch it for a number of reasons, but I think it's asymptomatic. I'd probably follow it, do a follow-up scan in a year or two. They grow slowly, but I doubt it'll even change over an interval of a year or two.
How would you follow it?
Just follow-up CT.
And at what duration?
1 to 2 years.
Anybody else? What if it's osteosarcoma? Is it going to grow
not.
faster? You sure of that? All right. Well, I said, have you ever had another CT scan in your life? Well, yeah, I had one a couple years ago. So I had her bring it in, and 2 years earlier, she had a CT scan, which showed the exact same size of this clearly osteoma. So if you can document that you have stability of the osteoma, you can breathe better. I did her sphenoid surgery, and she got 85% better. Her headaches were almost completely resolved. And then I'll follow up with that osteoma with another CT scan in a year, just to make sure.
Perfect.
Any questions about sinus dilemmas that have no right answer in our last minute?
I've got a lot of them.
I know. What do I do with the
Who do I
minimal
send them
frontal
to?
sinus disease? Yes, Dr. Puig.
Lately, I've had a couple of referrals with patients with sarcoidosis, and they have chronic sinusitis as well. And a couple of these patients have had surgery 2 or 3 times before, and it looks like osteomyelitis. Everything's inflamed, the bones thick, they've got the rind around all their sinuses, and they want sinus surgery because they're chronically infected. What do you guys do?
So we probably see a lot of those patients. I work with the rheumatologist and the pulmonologist, so I have a lot of sarcoid and GPA patients. You're not going to, you have to explain to her what's going on. Your surgery does not fix these people. In fact, I won't operate on a patient with active GPA because their noses literally dissolve. And I've taken care of a lot of patients who just, it wasn't picked up and they had surgery and it's a mess. So what they need is control of their disease. So they need to be on systemic steroids and steroid suppressing medications and immunomodulating medications. And I put them all on mupirocin and steroid rinses to control the crusting and the inflammation. But you have to tell them that your systemic disease needs to be controlled. And once that happens, then you're going to feel a lot better. I had a patient early in my career who had GPA, and I kept treating him for these recurrent infections. You know when his infections went away is when his GPA became quiescent, and instantly the infections went away. And it had nothing to do with what I was doing with that patient.
All right. Well, I'd like to thank our panelists for your time, and you can just leave your microphones on the chairs once you mute it. Not yet. You can drop the mic soon.